At the outset, I would like to thank Sanjay for giving me this opportunity and also Mysore Medical College for asking me to take this guest lecture. And most of this material is my original work. However, some illustrations I have used from internet sources for teaching purpose only, and I'm not using any of this for commercial purpose, and I don't receive any monetary benefits from this lecture. So what is MR spectroscopy? It is a non-invasive examination which can give us information on chemical makeup of a tissue. For example, if you take a lemon and if you scan a lemon, you get the spoke-like pattern of lemon in MR image. Similarly, if you can pick up the citrate peak within the lemon, that is called MR spectroscopy. MR spectroscopy assesses the cell metabolism, and it actually gives you metabolic fingerprint of the tissue. The basis of MR spectroscopy is chemical shift imaging. So MR spectroscopy for a first year, so most of the imaging we do is anatomical, is BD Chaurashia, and MR spectroscopy is biochemistry, and this is the Guyton and Hall physiology we see through fMRI and perfusion and other stuff. So this is how you remember what exactly, for a layman, if you want to explain MR spectroscopy, or a first year resident who wants to know. With MR, this is the only special modality where it covers the biochemistry and we can cover everything. Now we are into mostly genetical imaging, that's also coming. How is this happening? So the difference between water molecule and there is chemical shift difference between water molecule. Water molecule spins faster. It spins faster compared to the fat molecule. So the difference is definitely helpful, and everything we are plotting as a, see, for example, this side, this is how we get a MR spectroscopy. So some jargon like peaks we get, and definitely on this side, what you see is the lipid. This side is the lipid, this side is the water. What we are trying to tell you is every metabolite what you are seeing in MR spectroscopy falls in between water and lipid. So this side, it is 0. Lipid side, you call it as 0. And the other side is approximately 4. The difference is approximately 3.5 ppm. So between this, all the peaks fall in between this. We are using the chemical system imaging to diagnose the conditions, to pick up the peaks individually, and we diagnose individual peaks. So this is biochemical makeup and stuff we're going to go through the MR imaging and we'll see. So these were the, in fact, before biochemistry came. So MR spectroscopy, NMR was earlier. In fact, these people have done this work at 1947, but unfortunately it disappeared, and we need certain hardware requirements. At the end of the lecture, you'll be able to tell what is single voxel, multivoxel, short T, long T, what is press technique, what is steam, what is water suppression, chess, and artifacts also we'll be dealing with. So initially what I said, there was a lot of hype initially. At around, if you see 1990, MR spectroscopy came, and there was so much hype, see so many PubMed published articles at around 2005 to 2009. And there is sudden dip at around 2015. This is where I have taken the lecture, like maybe then why there was a dip in 2015 and 2016 because of lack of awareness and not following the proper techniques. There was people started not using MR spectroscopy anymore. It is definitely useful when you do it correctly. This is one of the best article written by Rakesh Gupta sir, and he's currently, he was ex-director of Sri Chitra Tirunal. What did he say? After initial euphoria, MRS is entering into the domain of clinical radiology, perpetrated by only few enthusiasts to able to diagnose everything by MR spectroscopy, and it has come a long way. Ultimately, why this is failing? Because the technical and suboptimal acquisition. So the technical part is very important to diagnose MR spectroscopy. So the biggest myth I would like to underline is the good, bad, ugly myth. It's the easiest way to remember. First year resident, if he wants to read and you want to simply communicate with somebody, sir, NAI, presence of NAI means good health. See the green, we have quoted it with the green. That means NAI is a N-acetyl aspartate is a neurochemical metabolite which says health. In fact, one of the important part of N-acetyl aspartate is it divides the MR spectroscopy exactly into two halves. And if you have a central good N-acetyl aspartate, that means it is in good health. The brain is in good health. For example, if I give a condition like Alzheimer's disease and I ask a resident what will happen to N-acetyl aspartate, naturally he should say, sir, there will be decrease in N-acetyl aspartate because Alzheimer's disease is a gliotic disease. So automatically there will be loss of lot of cellularity. So then there will be decrease in NAA in lot of areas in the brain. If you randomly sample multiple areas, definitely in the temporal lobes and parietal lobes, there will be decrease in the N-acetyl aspartate. Similarly, there will be other peaks like increase in myoinositol and all. This is all documented. So, but basic is N-acetyl aspartate will decrease in ill health. This is one first point. Second thing is choline is a bad metabolite. This you have to take with a pinch of salt. Choline is a bad metabolite. I totally agree. But any ill health will cause choline elevation. For example, infarct will cause choline elevation. Any cell membrane destruction, abscess will cause choline elevation. Any ill health will cause choline elevation. So, but for understanding sake, you can think choline is a bad. And we say lipid lactate is the ugliest metabolite. Why? Because lipid lactate means necrosis. Choline means cellularity. So this is how you have to remember. You should not remember that this is a good metabolite, this is a bad metabolite. This is wrong. What I say, lipid lactate. Whenever you see a lipid lactate peak, that means it is seen in a highly necrotic tumors like GBM, metastasis, and even in tuberculosis, where there is mycolipids and also central necrosis. So tuberculosis, when there is mycolipids and central necrosis, you will get lipid lactate. So understanding the chemical composition, you are not, in fact, you cannot judge it as good or bad. Okay, for example, I will give you a beautiful example. In a Canavan's disease and Pelagius-Merzbach's disease, there will be over elevation of NAA. So you've seen NAA peak means if there is too much of NAA, that means you are telling very good brain, excellent brain. No, it is a pathology. So please leave the concept of good metabolite, bad metabolite, and ugly metabolite. So this is a myth which you are following all these days. Again and again, I don't want to repeat. And these people recently from US Insurance, they have deleted MRS. That is a very drastic step. And this is a wonderful book actually. I have read this book during my postgraduate and written by Grossman and Yusuf. It is Neuroradiology Requisites. Most of you would have read that book. What they say is, you go to first page, everything except Canavan's disease has low NAA and high choline. So he made a sarcastic comment lightening things about MR spectroscopy. I strongly believe that is not true. It has its own advantages. And throughout my lecture, at the end, I will receive comments from you. This I already told. The chemical shift, exploiting the chemical shift will draw the metabolites. Again, lesson from chopstick. If an Indian is given a chopstick and say eat rice, Indians will say, hey, how can you eat rice with chopsticks? But when you go to China, these people will eat rice beautifully with chopsticks. Ultimately, they are not putting up weight. That's good that they are eating little. But if you know the proper technique, you can definitely eat the rice properly. That is what I say. How to acquire a good spectral wave. One of the most important slide of my lecture. Please write down or take a photograph or a screenshot, whatever it is. How to acquire true axial images. This most of the people who will not be doing it. What will they normally the brain planning will be done in to avoid the orbits and also to avoid the sinuses. Brain planning will be done in not true axials. Oblique axials they plan to avoid the susceptibility weighted artifacts. But whenever you are planning MR spectroscopy, you have to take the true axials. That is very important. Then you can plan it either on any T1, T2 post contrast or SPG or anything. Post contrast will not have added advantage. Without contrast also you can do a good quality spectra. But some articles say post contrast added better delineation of the enhancing area, so you can plan properly. Though you are planning it, make sure that your post contrast is acquired as an SPGR bunch and without any angulation or tilt. You sit with your technician, check for it. That is very important. Next is you should select what you are dealing with. Are you dealing with a single voxel or anything? This is all MR vendor dependent. You can go select most of the places where you use this press technique. We are doing point resolved technique. And this is very, 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 very important. Saturation bands. Normally, this is how you want to study this part of the brain. Now, what you should keep, you should not allow the signal from this area, this area, this area, this area to contaminate your voxels. So make sure that all the voxels are properly shimmed, or like you have suppressing the signal from that area, and you get the multivoxel or single voxel data only from this area. This is one thing you have to, this is very, very important. After saturation, you have to run the spectroscopic sequence and you get a spectral wave. So, okay, all you have followed and you got the spectral wave. You sat with your technician, you got a beautiful spectral wave. And you have to understand the spectral waves. You have three sequences in your vendor. One is short TE sequence, intermediate TE sequence, and long TE sequence. Sir, each sequence takes around 7 to 8 minutes. I cannot make the patient sit for around 21 minutes in MR gantry only for spectroscopy. Very practical, very practical. So I have to choose one. If you have to know what you are looking for, you have a conventional diagnosis before you are going for a spectroscopy. If you want to differentiate between low-grade tumor, high-grade tumor, you just go for intermediate spectroscopy. If you want to see a tiny metabolites like alanine, you want to see some branched chain amino acids. So all these things you have to see in the long TE that I'll be subsequently telling. And also in short TE gives your metabolites beautifully. There will not be any controversy. So if you, single voxel spectroscopy is one of the beautiful spectroscopy you can get. Unfortunately, you cannot compare with the surrounding brain parenchyma. You get only a single voxel in it, but you get a beautiful. So provided the best sequence is, best thing to run is intermediate TE around 135. Okay. This is the most of the times your technician can tell, run an intermediate TE sequence. So these are the peaks we get. So again, this is the most important thing. What I said is, this side is water, this is the king, water, and this is the lipid, which is on the other side. Everything falls in between. So if I say myoinositol, where will you see myoinositol peak? You should immediately go and search for myoinositol peaks will be raised in case of Alzheimer's disease. Suppose this is the subject you learned. Now somebody said, Alzheimer's disease, run a spectroscopy and tell me what is happening. So immediately you should go for this area and look for the myoinositol peak. If you do that imaging that way only, you will be able to find up some beautiful peaks. And following that, you will develop confidence over MR spectroscopy and you will do wonders over it. And I have done some cases which are really good. This is the choline. Where will you see? Next to 3.2, here you will see. Then in the mid portion is Na. Na is the tallest peak and it's in the center. So based on that, wherever you see GABA, you see glutamine. Glutamine is seen in some pathologies like liver failure, you see glutamine peaks. And as I said, this divides exactly the tallest peak in between it. This divides the spectrum. So this is the succinate. We have seen. I will show you the cases of succinate, acetate. I will show the case of alanine. And all these things we have diagnosed, including the amino acids. I have practiced it. Then I started diagnosing each of it condition. Okay. So this is how we have to go, single voxel and everything. So this I have already told what is short TE, what is long TE. So short TE is around 30 milliseconds. Long TE is 270 milliseconds. Then intermediate TE. One interesting part of intermediate TE is you won't get a lipid lactate above the baseline. You get below the baseline. So inversion of lipid lactate means that you're getting lactate. If lipid is there, it will be above. So this is called lactate doubling or J coupling phenomenon, which I'll be telling subsequently. So if you're seeing a peak like this, and if something is down, that means in a 135 milliseconds, that means you're dealing with a case of lactate peak. So this is steam. How the pulses are giving is 90, 90, 90, and mostly steam is used for single voxel spectroscopy with short TE sequences, and press used for long TE. And these are the pulse sequences given to obtain the press sequence. This is all technical, not much of important. In single voxel, I said no, the peaks are very clean. If you're looking for a small metabolites or you want a cleanest peak, if you have time on your side, you run one single voxel and one intermediate peak, both. Okay, that is very important. Then this is the multivoxal CSI grid spectroscopy. See how beautifully they're shimming the artifact from the other areas. There is no voxel bleeding. You'll not around. And this is for comparison from a normal side. And you are checking the tumor wall. You are seeing the center of the tumor. So by seeing this only, I'll know this will have normal spectro. This will have maybe, because it's in the wall, there will be elevation of choline. Cellularity will be more. This is in the center, so there will be more of lipid lactate. That is how I look at the spectroscopy. And again, what I say is you should always avoid calcification, metal, bone, blood products, air, and also CSF. So this is one very important. So the tumor will be sitting adjacent to the ventricles, and the tumor will have the margins here. So where will you place in the mostly in the corona radiata area? You should keep your multivoxel so that you will include only part of it. And it is better to avoid the bone. It is better to avoid the CSF space, and we have to place it in the corona radiata. And you have to see normal area, cover little normal area, and you cover the wall, you cover the center area also, so that you get the maximum spectral. Around if you get around 6 voxels, few with normal, few with abnormal, few with the center, few with the periphery, then you are doing a beautiful multivoxel and you get a lot of data in it. Okay. So this again, the controversy of gadolinium I already said, and almost some peaks will be elevated. You can use gadolinium. The first part, what will you see? Irrespective of whatever tea you use, there will be some metabolites which are seen in all tea, from short to long or intermediate. You'll see these peaks. Number one, this is the normal spectra. As I said, this is the choline, this is the creatinine, and this is the NAA. This is called Hunter's angle. It will be in the rising area. This will be like in ascending order, and you will see the NAA like this. Okay, let's see. And here, you're seeing here NSTL aspartate. See, what I'm trying to emphasize is like this is relatively healthy indicator. This is the biochemical. If you go back to Krebs cycle, or like if you go back to all the biochemistry you learned, you know where is the exact metabolism happening. And this is the largest peak in the brain, and it's a neuronal marker. It happens at around 2 ppm. And I've got the Vodafone Zuzus to help you. And this is 2.0. This is how you have to remember. This is a neuronal healthy indicator. And definitely this 2.0 is very important. You have to know where exactly the peak occurs. That one thing which residents fail to do, the peak location. And again, choline. Whenever you're telling, even when a seasoned chess player like Sanjay, they know bishop stakes NF3, something like that. They use the terminology to tell what has been, what pawn has been taken, what bishop has been captured, and all in chess. Similarly, you have to tell choline means immediately you have to remember, okay, choline, okay, 3.2 ppm, something like that. You have to remember and you have to make. And it is seen in cell membrane. Choline is seen in cell membrane. So anything which causes turnover, increased cell membrane turnover, will cause elevation of choline. Lymphoma, choline elevation will be there or not? So somebody in chat box can just type the answer, so it will be more encouraging for me. Lymphoma, there will be high cellularity, so more choline. Again, similarly, infarct, will there be elevation of choline? Yeah, cell membrane destruction, there will be release of phosphatidylcholine, and there will be increase of choline. Similarly, creatinine, this is a energy metabolite, and there have been cases of congenital creatinine deficiency diagnosed based only on MR spectroscopy, and in fact, it's a neuroradiology spotter for an exam final year DM students. They keep a MR spectroscopy there, and there will be creatinine peak which is disappeared, and they have to identify. If you don't see a creatinine peak at around 3.2, that means it's a congenital absence of creatinine. This one important thing which can diagnose by thing. And similarly, you can also see post liver transplant, this peak will disappear. And also in hepatic encephalopathy and malignant tumors, the creatinine will. Choline creatinine ratio is one of the best indicator of tumor grading and telling whether it's a benign lesion, a malignant lesion, or inflammatory lesion, or infectious lesion. Creatinine has such an important value. Creatinine is a very important metabolite. It is seen across all the short T, long T, intermediate T, choline is seen, and it is basically an energy metabolite. And as I said, lipid lactate is an indicator of necrosis. Whenever lipids come, either tuberculosis or necrosis are the two reasons for lipids to occur in the brain. So normally, as you know, that the periphery of the tubercular T1 hyperintensity is also attributed for that. The tuberculoma, the periphery will be hyperintense, attributing to the deposition of mycolipids. So that is one condition where you get elevated lipid lactate. Similarly, there will be lipid lactate elevation whenever there is a central necrosis in a GBM or a metastasis. Even tuberculosis, sometimes there will be elevation of choline when there is a high cellular turnover without necrosis in early phases. So what I'm trying to tell, the pathology, but definitely the ratios won't cheat you. So both choline elevation, tuberculosis choline elevation from glioma to choline elevation, how will you differentiate? Choline creatinine ratio, choline NA ratio, these things may help you. And again, going back to conventional imaging. I've been lucky to travel with a great neuroradiologist from our country. He has worked on 14,000 gliomas. And he just told, what is, sir, if I give you all the imaging sequences and I asked you to pick up one sequence to diagnose gliomas, what do you see? He said conventional imaging is the best. So similarly, at the background, in the light of conventional imaging, you can add some more information and add an edge to your reporting, because this understanding spectroscopy, perfusion, and also CSF flows, all these things are very difficult for a dedicated general radiologist, or even non-dedicated general radiologist, or even a neurologist or a neurosurgeon. So this adds a value to your reporting, which you should always inculcate. And lactate, as I said, lactate gets inverted around a inversion will occur around 135 to 145. So intermediate TE, somebody asked in the chat box already. The intermediate TE is a range, 135 to 144 or 145 or something like that. It's a range. It's not an absolute value. So 135 or some, again, it is vendor specific. It may change accordingly in the vendor specific. Again, this is an infarct. If you see, this is an infarct. This is our own case where there is gliosis on this side and there is a large wedge-shaped infarct on right side. And we have run an intermediate TE and we have seen the lactate inverted. So this is about lactate. And this is secondary to a phenomenon called J coupling, and too much of physics involved in it. And anybody who is really interested, you can go there. And now, if these are the metabolites you can see only with a short TE. So relatively, or like most of the metabolites, you may have an across contamination or anything, you can see these metabolites, which I'm going to show you. If you don't run a proper short TE sequence, you may not see such metabolites. Sometimes even see, everything can be seen in the across everything. But these, if you want to see, for example, if you want to see a proper myoinositol plea, see, myoinositol actually helps you grading the gliomas. The ratios, myoinositol to creatinine ratio. If you're really bothered about, generally, I don't follow this. I don't look for myoinositol in gliomas. I go back to the regular intermediate TE sequences. But if you're a real enthusiast, if you have time on your side, run a short TE again, look for the myoinositol. Where did I say myoinositol? Around 3.6. Okay, myoinositol is around 3.6. You look for the myoinositol peak around 3.6. There is a peak here. And this peak, sorry, this is the peak of myoinositol. So you can diagnose it. And I said in Alzheimer's, HIV, demyelination, there will be elevation of myoinositol. This is more prominently and better seen in short TE. This is what I'm doing. And this is again a wonderful metabolite. I have represented it with as a yellow bird or a yellow angry bird, yellow check. Why? Because I want you to remember that glutamine is elevated in hepatic diseases. So whenever there is a hepatic encephalopathy, there will be elevation of glutamine. So this is one of the commonest. See, this is where you see a glutamine peak and all. And to be honest, I have not really worked on it, and I have not really showed some interest in picking up glutamine in hepatic encephalopathy. And because it's more obvious, you will get the T1 hyperintensities, and you are already happy that you have diagnosed hepatic encephalopathy, and there is no point in going and putting an MR spectroscopy. If there is an indication, if somebody asks, I would have done it. But I didn't get a real indication. But you have to understand glutamine, yellow bird, and it is seen in hepatic encephalopathy. And this glycine is again from the textbook in Wandernap disease, CNET, meningioma. See, Wandernap is a cystic disease. So cyst, okay. Then CNET again is a bubbly looking tumor. So that is why I said, if you want to remember, where do you get glycine peak? This is in fact again MCQ asked in a lot of exams. So you remember these bubbles, angry bird. So glycine is seen in a bubbly lesions like Wandernap disease, Agarwal disease, or Wandernap disease, where there will be multiple cysts and macrocephaly. And also you can see in CNET, where there will be bubbly looking tumor. This is where you get it on immediately next to the myoinositol 3.5. And this is taurine. Taurine is again, this is a shade from our own. This is an article, I got it from article. So here, if you see borrowed image, taurine you can get around 3.4 in short TE only. If you want to see all these small you will see in the short T only. And why did I indicate? It is seen in medulloblastoma. Medulloblastoma is a blue round cell tumor. So taurine, if somebody has seen in medulloblastoma and even the embryonal tumors, blue round cell tumors. That is why taurine, Red Bull, blue color, blue. So that is how you remember. If somebody asks where you get a taurine peak, then you can tell it's seen in blue round cell tumor, embryonal tumors, and even taurine is seen in Red Bull. Something like that you can remember. And this is a pig gangrene. This we have demonstrated innumerable times. Whenever you see a cerebral abscess, you run a single voxel spectroscopy, you will definitely see succinate peak, acetate peak, and I have published a video on succinate peak in my radiology case videos. I'll share the link if people who are interested more on it is a real problem solving. Along with the diffusion, if you have succinate peak, just tell them to take to the OT and drain the abscess. That's all. There is no, it's a fingerprint, a metabolic fingerprint. You can definitely see there will be decreased NA and you can see clear elevation of succinate acetate peaks in a case of cerebral abscess. Again, sometimes you get the patients will be pumped with a lot of mannitol and a lot of other drugs. These things will cause some artifacts in the MR spectroscopy, especially in this case. See, myoinositol is 3.6. This you remember. Myoinositol is 3.6. Around 3.8, you get a mannitol peak. This patient was being treated for this lesion, which this lesion is a quiz question. That's why I'm not answering what it is. So you should not be confused with a water peak. So this is actually a case of a mannitol infusion, and mannitol can be picked up occasionally in our thing. And there was somebody who was asking doubt in chat box regarding alanine. Yeah, alanine we have seen so many times, and we have seen in regular 144, 135 intermediate TE also we've seen. This is my experience. If there is something not right about it, I can go and check once again. Already some questions about alanine happen. In meningioma, I've seen 4 or 5 times already. And we don't run spectroscopy for meningiomas most of the times. If you consistently run, maybe in 100 cases of meningioma, definitely in around 50 to 60 cases, you'll definitely see the alanine peak. It is, again, if you sit in a Viva, I would be definitely interested if your case is on neuroradiology. I will definitely ask this question about what is the peak seen in meningiomas. I have kept this bomb as a alanine indicator. So you remember meningioma, alanine peak, and the bomb. Why bomb? Because mother-in-law phenomenon. What is mother-in-law phenomenon in meningioma? Mother-in-law phenomenon in meningioma means the contrast in digital subtraction angiography, it comes earlier and goes very late, meningioma. So it has the blood. Similarly, when mother-in-law comes to your house very early and goes very late. So that is how you remember. See this angry bird with bindi. Remember alanine peak seen in meningiomas, mother-in-law phenomenon together as a map. And this is citrate and all. You can go and the pediatric brain tumors, you can see the citrate. I can go on and on and on. I've been looking for this Trehalose. I think I was very near in one case and recently, and again I've discussed with few of them and say it's controversial and just skip it. But definitely very soon, if you declare whenever there is a doubt of fungal abscess and proven cases, if you go back and redo your spectroscopy data, you can definitely pick up this Trehalose peak. Most of these Trehalose peaks have been diagnosed and published from Indian data only. Trehalose peaks. So ultimately, long TE sequences are being used for certain, and this is one of my prized position and one of the beautiful case which I have diagnosed personally. So this is actually a child was very sick after 9th day of birth, and they have got this patient for an MRI, and MRI was showing classical swollen thalami bilaterally, cerebral limb, and everything. We have seen this typical diffusion restriction pattern is seen in case of maple syrup urine disease. So maple syrup urine disease, we get this short chain amino acid peaks. So definitely we have to have this long TE spectrum to long TE sequences to diagnosis. I have run this long TE in a 3 Tesla, and you see this. Here almost you are not seeing in the intermediate TE, and we have run it in the short, and definitely I have picked up this at around 0.9 ppm. I have seen this beautiful isoleucine, leucine, vanille peak. So you whenever you see the source by practice, if you can diagnose those things and if you can demonstrate it to your friends, they'll definitely develop some confidence and they'll start reporting it. So ultimately, after this, all the peaks I have told, how to approach it. Finally, half pizza is MR spectroscopy in my lecture. The full pizza only happens with the conventional MR and clinical data. So first slice of the pizza is look for the Hunter's angle. Check whether I'll show it in the actual images. Then look for the individual peaks. Compare with the normogram. See, this is the compare with the normogram. This makes the 3 slices. Then comes the compare the ratios. This becomes the 4th slice. Look at the metabolic mass. This becomes the 5th slice. And you have to look at the other voxels also. This completes these 6 slices complete half of our pizza. Then you have to look at the conventional MR data and also clinical data to complete the pizza. So this is the first thing. Look at the slice number 1, look at the Hunter angle. Slice number 2, look at the individual peak. So again, what I said, MI, monoinositol. Then you have to look at the choline. Next is the creatinine. And you have to see at the NAA. Okay, this is the peak. And also there are some small individual peaks. You have to look at them. And again, this is the abnormal peak. Compare with the normogram I said. So here there is elevation of choline a lot and there is decrease of the NAA. And look at the metabolic map. Sorry for the drawings. And here, this is the first map is the NAA metabolic map. This you get in this is from a GEMR. You get similar metabolic maps from all the vendors. You have to sit at the console and see. So this is the choline map. See this tumor without seeing anything. So I'm seeing so much red in the metabolic map. That means this is a highly cellular tumor. And I can tell the person, neurosurgeon, to take a biopsy from anywhere from this area. Similarly, if you would have done this on some necrotic tumor, if the metabolic map is showing only the cellularity in the periphery, and if a neurosurgeon you have not guided him properly, he may go into the center and take a biopsy, and he may not get the actual cellularity, which may lead to this. So imaging is to help others. Similarly, see the metabolic map of choline. It gives a valuable information that you are dealing with a cellular tumor. High cellularity is an indication for the biopsy. Again, so after that, you have to look at the individual peaks. See the ratios here. In this is again a GEMR. You are seeing creatinine to NA ratio, NA to choline ratio. So some new vendors like United Imaging are giving clearly in a tabular form, and this can be relatively challenging for junior. But they're giving in a tabular column that's more easier. So this is again, we can look at it, choline to creatinine ratio, choline to NA ratio here at this side of the bar. And ultimately, you have to check everything what you have done in the light of conventional imaging data. See, this tumor has a lot of extensive vasogenic edema. And the tumor is again, there is another lesion in the here. And if you see, you are comparing here with the multiple voxels. You are seeing the center of the tumor is seeing one voxel. Number 1 is showing some spectroscopy. Number 2 voxel is showing some spectroscopy. You will analyze the data in all the voxels. Then only you will come to the conclusions.